some spaces that's on the table because there's some external people who registered, but as they haven't arrived on time, I think if people want to move to the table, that's fine. Otherwise, there may be some chairs outside if people don't have a place to sit. And we'll be starting, I think it's time. So I'd like to welcome everyone to the 76th Global Health History Seminar. We've had these now for nearly 8 years. We're in the 9th year now of our seminar series. And again, we'll have the seminar series this year is on universal health coverage. That's the overall theme. And in that theme, we've got specific topics that we're covering. Today's seminar is going to be on Sri Lanka and the example of primary healthcare, particularly in Sri Lanka. We have two excellent speakers lined up, which we'll have presentations from each, and then we'll open up for questions. So I'll start by introducing our first speaker, who is Dr. Margaret Jones from the University of York, where she is the Research Fellow and Deputy Director of the Center for Global Health History, which has recently become a WHO Collaborating Center. So we're very happy about that. And Dr. Jones has a lot of experience actually in working in Sri Lanka. She's the author of 2 publications on the history of public health in Sri Lanka. She's also worked in the West Indies in Jamaica. And she's obviously a historian and she was educated in England and has degrees from Warwick University and Bristol University. So I'd like to ask Dr. Jones to make a presentation. Thank you.
Good afternoon. I think it's good afternoon. What? Oh, is that in the wrong place? Okay. Thank you for that introduction, Human, and thank you all for coming. A lovely picture of a hospital in Sri Lanka, which was built in 1901, so which is still there today and functioning, I think. My present research is an exploration of primary healthcare in Sri Lanka from 1950 to 2010. This builds on my earlier work on the history of public health in colonial Sri Lanka, and it's part of a wider project on South Asia, which is directed by Professor Sandra Bhattacharya, my friend here, at the Center for Global Health Histories, University of York, and it's funded generously by the Wellcome Trust. Now, the concept of primary healthcare has been subject to shifting and at times competing interpretations, as last month's seminar so effectively demonstrated. Does it mean the provision of services for basic, preventive and curative care, a first port of call and or a gatekeeping facility, or does it encompass the wider issues of agrarian reform and anti-poverty strategies? And should it and can it be a mechanism to empower people and communities for broad developmental purposes? Now, these different definitions could in part be seen as a historically evolving process, but the meaning of primary healthcare, now termed usually universal health coverage, is still a critical area of debate given the continuing health disparities within and between countries. And the point of the project that we're doing at York is that, as Socrates Lipsius argued in a 2007 seminar, not loud enough. Oh, right, sorry. Oh. Is that better? Yeah? Okay. Historical reviews could, as he said, quote, uncover many valuable experiences that have not as yet been documented or have been forgotten with the passage of time. Now, I'm going to give you a very brief introduction to the history of Sri Lanka for those of you who might not be aware of it. the map, obviously, Sri Lanka. Colombo down here on the southwest is the most populous area, and that area was first to be colonized, that coastline around there. Right, Sri Lanka, the teardrop on the southern tip of India was the British Crown colony Ceylon from 1805 until independence in 1948. It set the pattern of Crown colony government from the 1830s and was deemed Britain's model colony. A vibrant economic sector based on the export of primary products made it a wealthy colony. 400 years of colonization had created a highly westernized elite who from the 1920s began to challenge British rule, and in 1931 the demand for self-government resulted in the Donoughmore Constitution that established a state council elected on universal suffrage. And that's just 3 years after Britain had universal suffrage. There followed nearly 2 decades of decolonisation where the Ceylonese had responsibility for all aspects of government except foreign policy. The island's population, numbering about 7 million in 1948 and 20 million today, is heterogeneous, composed of different social and ethnic groups distinguished by language and religion. Broadly, you can divide these into 3 main groups. The majority Buddhist Sinhalese community, the Hindu Tamil community, the largest minority, concentrated in the north and the east, and also the Indian Tamils who were immigrant labour brought in from South India in the 1840s onwards to work on the coffee and tea estates. Although sharing religion and language with the Tamils of the north, they constituted a separate group. There is also a small Muslim minority. After independence, for the first decade, English remained the official language and government continued to be dominated by the Colombo-based English-speaking westernised class, but with increasing tension between them and the Sinhala-speaking non-westernised elites who felt cut off from access to status and power. It was to this group that Sinhala nationalism had most appeal, and in 1956 they were instrumental in the election of the SWD Bandaranaike government that gave pride of place to Sinhala language and Buddhist cultural values, and ushered in an era where governments became much more contentiously politicised and communal tension erupted, ending ultimately in open conflict. However, even despite economic, political and social problems and 30 years of bitter civil war that ended only in 2009, Sri Lanka, now deemed a low middle-income country by the World Bank, throughout the second half of the 20th century and into the 21st, consistently maintained overall exemplary health indicators. As Table 1 shows, in the first decade of the 21st century, it has health indicators on a par with much richer countries, and this is done, as can be seen, with a relatively low national income and health expenditure, which you can see if you compare it with the UK on this table. This record has made it something of a cause célèbre in international health circles and has served to make Sri Lankan experience worthy of close analysis. So in this talk I want to unpick the origins of this experience and try to highlight the factors that I think are significant to the story. So talk will be in 3 parts. I'm going to begin with an overview of factors in the colonial period that left a positive health legacy to the post-colonial state. Secondly, I'll explore the problems of healthcare that faced Sri Lanka in the first decades after independence. And thirdly, outline briefly the immediate government response to the Alma Ata Declaration of 1978 on primary healthcare. Sri Lanka's positive health record dates back to the late colonial period. It underwent its transition to a modern health profile in the 1940s, and before independence in 1948, it had what is preeminent historian Kinkley de Silva termed as an embryo welfare state, based on free education, food subsidies, and crucially free healthcare at the point of delivery, which was provided by the state. This was not a situation replicated anywhere in the British Empire, or probably any other empire, I'm not sure though. A number of factors contributed to this positive legacy. These were firstly, civilization of the colonial medical service. From the foundation of the Civil Medical Department in 1858, Western-trained Ceylonese were providers of state medical care in hospitals and dispensaries. They trained in Ceylon at the Colombo Medical School, which was founded in 1870. By the 1920s, only the highest posts in the Colonial Medical Department were reserved for Europeans, and in 1936, the last bastion of colonial privilege fell when the first Sudanese was appointed medical director. This was a first in the British colonial context too. And this is significant because at crucial points in the development of the medical services, it was from these Colombo-trained professionals that pressure for expansion of the health services to the general population came. Secondly, after universal suffrage was granted in 1931, there was a rapid expansion of healthcare services in the 2 decades following this through to independence. According to the economist Gunnar Maddow, for example, the decision to enfranchise women of Sri Lanka on a par with men was done to generate pressure to bring in services for women and children, which is particularly important for improving health. Thirdly, devastating malaria epidemic in the mid-1930s, 1934 to 35, with an estimated 80 to 100,000 deaths, was instrumental in extending the health infrastructure to hitherto neglected rural regions. And in 1937, anti-malaria measures were included in the public primary healthcare activities of the health units, which I'll come back to in a minute. Oh. Sorry. Am I doing something wrong? No. It's quite likely I'm doing something wrong. I'm not looking at that. The epidemic was also instrumental. Is that me? Yeah. The epidemic. I need to step a bit. It's too close now. Better now? Yeah? Can you hear me? Yes? Actually, no response means no, I think. Bit nearer? Okay? Yes? Is it still iffy? Up a bit. Is that better? The epidemic was also yeah, okay. The epidemic was also instrumental in exposing the widespread poverty of the Sinhala peasant. This entrenched welfarism in nationalist elitist politics and shaped public policy and state interventionism in the first 3 decades after independence. Free education, Sri Lanka was notable for its levels of female literacy, about 44% in the mid-1940s, for example. And since women are the health producers in families and communities, this was, I think, a significant contributing factor. The experience of the traditional medical systems, principally Ayurveda, alongside Siddha and Unani, was also singular. Under colonial rule, Ayurveda may have declined in status, but not in availability or use, and it was an integral aspect of the cultural revival and political nationalisation of the first decades of the 20th century. In the mid-1920s, the colonial government established and subsidised a board of indigenous medicine and a training college, and Ayurvedic physicians set up their own professional organisation. In 1935, professionalisation was further cemented with the establishment of the Ayurvedic Medical Council and an Ayurvedic hospital. Ayurveda was thus officially recognised and subsidised by the government, although minimally compared with expenditure on the Western medical services. This meant, however, that traditional medicine was, from the onset of independence, an integral part of the official medical landscape. Furthermore, it's argued that Sri Lankan cultural norms paved the way for willing use of available healthcare services. The indigenous medicine of Sri Lanka places, and cultural values place great value on good health and shows a fatalistic attitude to illness, so Sri Lankans' health-seeking behaviour predisposed them to accessing medical aid in whatever form. Moreover, Sri Lanka had an extensive preventive healthcare system from the 1920s. In 1926, as a collaborative venture between the International Health Division of the Rockefeller Foundation and the Colonial government, a health unit was established at Colonial. It was model on the scheme successfully used by the Rockefeller Foundation in the American South. The program of work for this first health unit, and this is a photograph of a photograph that I took in the museum at Colonial. This is the first health unit, and that's Dr. Chalaba, who was the first head of the health unit. It included maternity and child welfare services, health education, sanitary work, communicable diseases work, and school medical inspections. The purpose of the health units was preventive, not curative. And as they expanded across the island, they formed the basis of the primary healthcare infrastructure still present today. To conclude this section, the legacy of the colonial period was that no Sri Lankan was denied medical treatment and care because they could not afford to purchase it. This was no mean achievement, and it was a commitment that the new nation was more than willing to take up. In 1949, Bandaranaike, who was then Minister of Health, declared his government's acceptance of the WHO's concept of health as a fundamental human right. All governments since have recognised and maintained this commitment, and Sri Lanka has continued to be seen as exemplary. Whilst lauding this record, however, contemporaries in the first decades after independence acknowledged the ongoing problems. These were, firstly, inequalities in access and coverage, the ad hoc and at times capricious establishment of medical institutions, sometimes depended on the MP having a loud voice in Parliament. By 1970, there were over 2,000 hospitals of various kinds, but meant that there was a vastly uneven spread of services. The rural poor, who made up 70% of the population, was ill served by this infrastructure. And if you look at Table 2, which illustrates this rather crudely, obviously, by doctor population ratio, and if you look at Colombo, which is the heavily populated areas where the main hospitals are, and compare that, say, with Babunya and Adnanapura, you can see the difference. Apart from these geographical inequalities, there were also disparities between ethnic groups, whereas in the colonial period, the Tamil estate workers often had access to better facilities than the Sinhala peasant. They suffered far less in the malaria epidemic of 34-35, for example. That situation reversed as the estate workers' position worsened. The denial of their citizenship in 1949 and the projected nationalisation of the tea estates throughout the 1960s meant that medical services and therefore their health indicators noticeably deteriorated in relation to the general population. For example, between 1972 and 75, the IRMR rate on the plantation sector was 100 per 1,000 live births, which was twice about the reported national average. Moreover, there was little coordinated planning in the use of the health services. There was no structure of referral, and naturally people chose to go to the hospital that had the specialists, the best facilities, medical technology, and the drugs. Therefore, in large urban hospitals of Colombo especially, were always oversubscribed. Overcrowded. Somebody objects to what I'm saying. And the smaller provincial and district institutions underutilised. An offshoot of these problems was that it was hard to persuade doctors to work in rural areas where career and monetary rewards were more limited. The Ayurveda sector was government-funded, flourishing, and much used, and the ratio of government funding between Western and Ayurveda sector increased from a ratio of 73 to 1 in 1946 to 18 to 1 in 1972. But this still made up only about 3% of total health expenditure. Their services were easily accessible, estimated in 1972 that the average distance to an Ayurveda practitioner or institution was less than 1 mile. And as Similar argued, they constituted, quote, a system of providing services spread over the whole country, but crucially, he adds, they did not participate in either family health or in the control of communicable diseases. In 1950, the government had requested Dr. J.L. Compton, who was ex-Director General of Health in Australia and also a proponent of social medicine, to report on Sri Lanka's healthcare services. One of his major criticisms was that the administrative separation between the curative and the preventive sectors to the detriment of both. The separation had erupted when he was actually on the island into almost open conflict between the within the medical department over the appointment of a new director of health services, because traditionally it had always gone to a public health position and it was given to a clinician. The absurdity of this division, I think, was brilliantly satirized in this Ceylon Observer cartoon in February of that year. So that's Compton standing there in the doorway. That's Bandaranaike, who's Minister of Health, with his head round the door. And you can see the curative and preventive twins going at each other. And the poor Sinhala peasant suffering. And the fact that most of the money went to expenditure on curative rather than preventive can be seen in this table, which is also taken by D.L. Siminos' report for the WHO in 1975. Huge difference between the money spent on cure and the money spent on prevention. It was also recognised from the 1940s that despite the dramatic fall in mortality rates, the incidence of morbidity as a result of preventable illnesses was still unacceptably high. But what was needed was, quote, a health policy rather than a disease policy. This was said by the Director of Medical Services in 1945. Critics of the government's 1955 health plan, for example, also argued for switching expenditure from hospitals to the creation of positive health. The leading cause of admission to hospitals were still diseases of the respiratory systems, infectious and diarrheal diseases. However, these hospitals were the visible symbol of Sri Lanka's free health service, and as Malinga Fernando, who was Director General of Health in the 1980s, put it to me in 2004, that free health service was, quote, a clear and potent political issue. Switching resources from preventive public health was a highly politically contentious issue. And of course, positive health cannot be provided in a vacuum. The underlying cause of much of this ill health continued unabated, such as the lack of safe water supply and sewage disposal systems in many areas. The dilemma for Sri Lanka was how to satisfy legitimate aspirations of the public to secure the benefits of medical progress with the long-term goal of preventing disease. I should say was and is, probably. Or as the director of the Colombo Hospital rhetorically asked in a newspaper article in 1970, was it more important to improve sanitation, nutrition, health education, and provide basic facilities for health and patient care for the masses of this country, or was it more important to go in for sophisticated and expensive programs like heart transplant units? To conclude this section then, as Malinga Fernando again argued in a 1991 paper, there were deep roots to the development of primary healthcare services in Sri Lanka, and it came to be used as an example at the international level of what could be done without the levels of expenditure common in richer industrialized countries. The Sri Lankan example was an essential part of the context as primary healthcare took center stage at international level in the 1970s. Furthermore, given the extent of its hospital-based curative system, it was also a perfect illustration of the limits of that model for low-income countries in the context of a burgeoning population and economic crisis. Now, at the macro level, Sri Lanka responded quickly to the aims of the Alma Ata Declaration and attempted to restructure their health services accordingly. Although I should say that many of the changes that were brought in 1979-1980 were already in process and had been since the 1970s. But of course they benefited from the added impetus coming from Alma Ata Declaration. Now, Health for All was to be implemented firstly through in 1980 through the National Health Council. This was to be chaired by the Prime Minister plus the Minister of Health and ministers from other relevant departments. The intention was that it would provide, quote, political commitment at highest level as well as policy guidelines for health development within an intersectoral framework. It was felt that without the political weight of something like this council, the danger was that health planning to reduce inequalities would remain a paper exercise only. The healthcare system was restructured into a three-tiered primary healthcare complex in the shape of a pyramid. Now, I'm saying this is the plan. I haven't yet got as far as working out how much was put into practice, so maybe Susie knows more about that. The main thrust of this decentralization was towards, quote, the total development of people at village level. At the base, so this is clearly the broadest definition of primary healthcare. It's talking about development. At the base of the period was the village health centre, headed by a public health midwife, also termed a family health worker, who was to be the first point of contact with the healthcare delivery system. The objective was to decentralise services and make them more accessible to all. The principle of community participation was to be implemented through the mechanism of the Village Development Council, the main organisation for all community development activities, which included health. Health volunteers were to be actively involved in identifying and meeting the health needs of the community, and they were expected to be important agents for change. This use of health volunteers was not new, had already been accepted by the Evolving Health Education Bureau. The traditional medical practitioners were also perceived as a significant member of the health workers team and were to be involved in health promotion and disease prevention and to give, quote, collaborative support to community care. They also were already being used in the family planning programme. Between 1976 and 78, for example, over 700 have been trained in family planning methods. In 1979, the National Institute of Health Sciences was established. This photograph I took last year because I thought it was just such a beautiful building. Was established at Colonial, which was the site of the first health unit, to train manpower, assume the leadership role in curriculum revision and the training of primary care workers, their supervisors and teachers. Again, this first health unit had been a training institution and a model of good practice from its establishment. So this was a kind of redevelopment, restatement of those aims. And primary health care was accepted in Sri Lanka as encompassing these 17 points. Right at the top, you see proper and adequate nutrition, safe water, basic sanitation. At the bottom, health education and community organisation, and in between, what really you'd expect to see there. Despite the positive aspects of the Sri Lankan case up to and beyond 1978, as outlined here, however, a 1980 CERO paper, which was entitled Strategies for Health for All by the year 2000, presented in stark terms the quandary that Health for All presented for Sri Lanka in 1980. I think this paper was written by Malinga Fernando, but I haven't been able to confirm that. He was certainly the delegate to the Alma Ata declaration, and I think it kind of sums up the problem then, and maybe also today. There is as yet inadequate appreciation by the general public, the opinion makers, decision makers and resource allocators that the fundamental health problems of this country remain as they were 2 decades ago, deeply rooted in malnutrition, inadequate water and sewage and housing, and the inadequate control of communicable diseases. The widespread publicity which the curative services attract obscures the inescapable conclusion that though the curative services can and do relieve illness in the individual patient, it produces negligible effects on the persistence and spread of diseases in the community, whereas an effectively planned and executed primary healthcare scheme can contain this morbidity. The irony of this situation lies in the fact that Sri Lanka has already provided one of the most dramatic illustrations of the efficacy of this approach. So Sri Lanka's primary healthcare success up to Alma Ata was evident in its reduction of mortality rates, but the challenge to Sri Lanka remained and remains that of finding the most effective route to reducing morbidity, now ever more pressing with the demographic transition and the resulting double disease burden. Thank you.
Thank you, Dr. Jones, for great presentation, and I'm sure there'll be some questions afterwards. I apologize for the temperamental sound system, but well, I think it's a new system and it still needs to be adjusted slightly. Before I introduce the next speaker, I forgot to mention at the beginning that this seminar we're following is actually the introduction to a 2-day workshop on health, humanities, and global health. So when this seminar finishes, we'll have a short break. There should be some sandwiches provided, and then we'll continue in the afternoon session through until 4:30 today. And then tomorrow, the workshop continues at the Graduate Institute in Geneva. By the way, there's a couple of chairs here at the front if anybody wants to sit, and there may be some other chairs at the table for those who are still standing. Okay, so our next speaker is Dr. Susie Perera, who's a senior official in the Ministry of Health in Sri Lanka, where she's Director of Organization and Development and of Policy Analysis and Development. Dr. Perera has interest in migration and migration policies, primary healthcare policies, and policies for universal access. She has a medical degree from the University of Colombo and has a master's degree in community health and a doctor's degree in community medicine. So she's very well qualified to be our second speaker, and we look forward to hearing her presentation.
A very good afternoon to all of you, and thank you, Professor Bowman, for that introduction, and also thanks to Sanjoy and to Margaret for having me out here to speak to you. And taking on from where Margaret explained the policies that shaped primary healthcare development in Sri Lanka, I would like to talk in the present context and what might be the future for us. And okay, so even before Christ, we actually had, you can see some remnants of archaeological remains of hospitals. I won't say too much about that, but in the middle there is a facility which is really one of the primary care institutions, and we also have the modern day hospitals. On this side is the Lady Ridgeway Hospital, the premier hospital for pediatrics, and another hospital which is a base hospital which is in the eastern region of Sri Lanka. Okay, so the Sri Lankan health system consists of two main providers, but by far and large, the government is the main provider of healthcare. And according to Medical Statistics Department of the Ministry of Health, in an unpublished figure, approximately 5.8 million hospitalizations took place in 2012 in the government hospitals. During the past 5 years, roughly the proportion of hospitalizations in the government sector from all hospitalizations remained around 90 to 95%. So the government is the main provider of care, and outpatient utilization, of course, is slightly different. There is almost equal distribution of patients between the private and the public sector. But the perception on the patient's confidence, I must say, to provide health in government hospitals is generally good. So there is a good perception that we provide good health care in government hospitals. The private sector, on the other hand, has become too costly for a person with an average income to be hospitalized. And with very few privately insured health, the government hospital system is providing a safety net. So the main mechanism of financing is the general tax-based system. And if you see, successive governments of Sri Lanka have been committed to providing free health care throughout the hospital and the community health service network. Throughout the island, we have about 1,044 hospitals which are categorized like this. And if you take, if I may refer you to the base hospital level, this is the level which has basic specialties of general medicine, general surgery, pediatrics, gynecs, and in many of these hospitals also there are the specialties of ophthalmology, dermatology, pathology, so forth. The divisional hospitals that are mentioned here of 3 different categories, these are the primary level hospitals that do not have specialists, and they provide for special hospitalization and for outpatient care. The primary medical care units are the ones which are managed also by non-specialist doctors, and they provide only outpatient care and sometimes emergency obstetric care. Now, apart from these curative hospitals, there's certainly a large network of community health services which were described by Professor Margaret. And these, of course, in this picture, you see all these dots represent health institutions. And coming to the health units, which were mentioned as by Professor Margaret, there are 341 now, and these are managed by MBBS qualified doctors known as medical officers of health, MOHs, we call them, and they have defined geographical boundaries that generally correspond to the local administrative divisions in the country. Therefore, some MOHs may have small populations, like about 20,000, while some might even have about 200,000 or more. So that's the extremes, right? The MOHs are supported by field health staff who mainly provide promotive and preventive health services. The services provided, as you can see, I won't read this list, but you can see these are the main the services that are provided, and the team that provides community health services are the medical officers of health, public health nursing sister, public health inspector, public health midwife, all of whom are recruited as health staff by the Ministry of Health and who have undergone a formal training. And the system is really a continuation of the health unit system that was introduced with the support of the Rockefeller Foundation. But the scope of interventions have expanded, as you saw in my previous slide, right? But from what I said, still the main focus is maternal and child health and communicable diseases. And recently, with the development of the national policy to address chronic non-communicable diseases, the policy which was launched in 2010, there have been activities added such as screening for cardiovascular risk factors, and there is also expansion of the child health services, which previously focused on under 5, to adolescent health, who actually comprise 20% of the population. So public health midwives provide mainly maternal and child health services, and they also do home visits in their defined areas. Now, on this side, you see the geographical units, the administrative divisions, for which there is an MOH or a health unit. On the other hand, The curative system, right, really does not have definite boundaries. So there can be people accessing from all parts of the country to any health unit. So there has not been any gatekeeping system as such for the curative system. The private sector largely concentrates on providing curative health services. However, we see that there are the private GPs and government doctors are also allowed dual practice, that is to work in the private sector after their duty hours, that is after 4 p.m. But they too provide to some extent preventive health services and also which are through the antenatal clinics and immunization clinics. So that is really in a nutshell about the service structure. But if we consider health outcomes, in Sri Lanka, maternal mortality has reduced significantly, and mothers now prefer to deliver in hospitals which have specialized obstetric care. In fact, only 10% of the deliveries now occur in non-specialist primary level hospitals. With this, we even see the antenatal care being duplicated, where mothers attend both clinics at primary care conducted by the MOHs and also the antenatal care with the obstetricians, which can be either in the government sector or the private through private consultations. Now, the monitoring and evaluation system was put in place, but it has been improved over time, and this is actually paying its dividends. And if one might consider the whole community health services has a good monitoring system, and it's possible to further track and develop through this. And this is actually one major contribution to the success of the maternal and child health program. And similarly, surveillance and monitoring systems are also in place for communicable diseases and the immunization program. So if we take the past 2 decades, health outcomes that have been largely considered when assessing the country health system performance have been maternal mortality, infant mortality, immunization coverages, stillbirth attendance at deliveries, and which really focus on the MCH and communicable diseases. So based on such indices, Sri Lanka is often described as a good model of healthcare, where the public health programs or the community health programs are delivered by well-trained staff, who have clear job functions. And with this improved availability and access through the expansion of the health units, but of course with defined boundaries, and also contributed by the fact that the specialized hospital network has expanded, have contributed to these achievements in good health outcomes. The people too have contributed to this achievement, and that has been the health-seeking behavior for maternal and child health and communicable diseases, which has improved through the free health and education policies and female empowerment. It was actually easier to make use of tools like the pregnancy record and the child health development record to benefit the people, to make them participate in their health actions, because when they are literate, that is possible to make them participate in their health actions rather than making these records simply only for the benefit of health personnel. So in Sri Lanka, we are now faced with different health challenges. And these are the ones posed by non-communicable diseases, including chronic kidney diseases, mental health, cancer, elderly care, we have the fastest aging population in Southeast Asia, injury prevention, different emerging and re-emerging communicable diseases, health of migrants. We have almost 2 million population who are outbound migrants. There are increasing inbound migrants, and we really need to review whether this model that we are speaking of today is good enough for us, whether we can still go ahead with this system. Now, chronic diseases need continuing care, and therefore it is expected that there should be more clinic visits over time to primary level institutions. What we are seeing are overcrowded clinics conducted in specialist level hospitals with relatively low numbers in primary care. Several studies carried out to determine reasons for bypassing of smaller primary level institutions point to deficiencies in care, availability of drugs, and laboratory tests. So when we actually consider that these are important health challenges, then the existing health model needs improvement. And certainly existing network of health facilities throughout the country gives a potential access that we can use for better utilization. There's been a slight mix-up of slides, but anyway, let me get back when I find where they need to come in. The out-of-pocket expenditure. Now, there is commitment from the government to continue provision of free healthcare through the government-managed healthcare organization. But the government has also promoted expansion of private health industry to provide for those who cannot afford it. The share of hospitalizations have remained almost the same, which I said it was 90 to 95%, indicating continued government sector dominance. Now this shows that the government system still provides this safety net and maintains its commitment to provide free health care. However, outpatient visits to private sector have also increased, and with disease-specific out-of-pocket expenditures, when they were analyzed, it was seen that the out-of-pocket expenditures for some chronic and non-communicable diseases were significantly high. So the green part is actually the government contribution, the blue part is private out-of-pocket expenditure, and you can see that apart from these conditions, cancer care, yes, the government supports. Also ischemic heart disease, yeah, for cancer care and for acute myocardial infarction, the government is taking care of people, but there is high out-of-pocket expenditure for the other conditions that I mentioned here. So it was also seen for cardiovascular disease, especially medications like statins. There was inequity in distribution at primary level institutions which had lesser availability. Now these factors also resulted in bypassing of primary level institutions, although we have this extensive network of primary level institutions. So although patients visited government outpatient clinics, they would have to purchase drugs. And also there is the lack of confidence in primary level curative institutions because of lack of medication and laboratory facilities. Now, as primary medical care units are about 400 in number, and they do not function after 4 p.m., patients in these areas would have to access private care, although it may even be the same government doctor who is providing dual practice after after 4 p.m. Now, decentralization and health system responsibility for primary care, it is important because there are several policies that are relevant here. In 1989, the health system was decentralized. The amendment to the government constitution known as the 13th Amendment resulted in devolution of power to provincial councils. This, which was mainly done as a possible solution at that time to the ethnic conflict. With health system decentralization, the responsibility for management of larger specialist hospitals was retained with the Central Ministry of Health. Other central functions such as procurement of drugs for the entire country, recruitment and deployment of major categories of health staff, basic training of some major categories too were retained with the Central Ministry of Health. The provincial councils had to take care of some of the base hospitals, some specialist hospitals, but their key mandate was to manage all primary level services, both curative and preventive. So the policies for expansion of specialized services are also important to consider, because in 1999, the government adopted a major health reform with the intention of expanding specialized healthcare in an equitable way. The reform was that every district should develop at least one base hospital to the level of a district general hospital. So some of these hospitals had to be developed with external donor funding, but for a long time, external donor contribution to total health expenditure has been less than 5%. Right? So, but the donor contribution is important when for big infrastructure development projects. Right? So there was a huge development agenda, and master plans were developed for each of the hospitals that were identified around the country for this upliftment of status, from sometimes from a primary level institution to a base level institution or a district general hospital. Right? But it became difficult for provincial councils to manage some of these hospitals which became larger. And for managerial efficiency, they were taken over again by the central ministry. Now, the infrastructure development that took place paved way to accommodate more specialists after their overseas training. So overseas training in Sri Lanka is mandatory for all specialists trained in Sri Lanka. This is one way in which Sri Lankan health system has advanced with the overseas exposure in developed health settings. Now, if you look at the capital expenditure budget for the Central Ministry of Health has always been higher than that for provincial councils, although there's almost equal distribution of staffing. The lack of funds in the provincial system has been an impeding factor contributing to lack of maintenance and difficulties to improve the image of these hospitals on par with the larger specialist hospitals. Right? So therefore, the development emphasis has been mainly for capital improvements in larger hospitals, as provincial councils received smaller amounts of funding, which was not sufficient. You can see down the trend that has been more allocation to the central ministries versus provincial councils. However, the reform program for expansion of specialized services was well received, and today we can boast of good infrastructure of larger hospitals and making it possible for specialists who come back after overseas training to be deployed in these hospitals throughout the country. The facelift has also had an effect on people's perception, and this contributed also to the bypassing of smaller primary level curative institutions, especially as there is no gatekeeping policy. Further, it was seen that the larger hospitals were favored for human resource development. And the specialist institutions actually became bigger. Although the medical officer population ratios throughout the country improved, some of the smaller hospitals became non-functioning because of understaffing and also only temporary functioning with visiting doctors going from larger hospitals. So you can see that some policies had a negative effect on development of primary level institutions. So considering all these facts, it was necessary to rethink how best the health organization, particularly the primary care structure, should be best utilized to address health needs that have arisen due to the epidemiological and socio-demographic transitions and also the rising expectation of people. The Policy Analysis Unit of the Ministry of Health began an analysis on how a rational model can be developed from about the year 2008. And this analysis of evidence on service gaps, etc., were collated after many expert consultations. And the primary care structure was discussed by a large group of Sri Lankan experts in different disciplines, and three basic configurations were discussed for delivery of care for chronic diseases. Now, there was consensus that the existing model should be further expanded to adopt chronic care needs rather than setting up a parallel structure for non-communicable diseases at primary level, and that there should be better service linkages between the primary level curatives and preventive health delivery organizations. So another important transition that we have to make is from episodic type of patient management to continuing personalized and family-centered care, which is now more appropriate for NCDs. And Sri Lanka would need to develop more competencies of this type of care. The principles of family medicine is relevant and needs to be better integrated to the health staff training. Further expert consultations contributed to consensus for 8 strategies to strengthen primary level health care, which would bring curative care and the community health services both to be considered in reorganizing. Now, in 2010, I call this a midpoint revelation of a future reform. All the evidence that we had gathered from the investigations that we carried out, the various research, we put them into large size posters. Why I'm showing you this is because the reforms are very complex and several, and we needed time, and just PowerPoint presentations were not going to be enough, right? So the posters too were developed through several workshops, bringing experts together, and this too had a reinforcing effect on the need to revitalize and reorganize primary health care. So these posters were used thereafter to inform several professional groups and engage them in further discussions and to advocate and get more ideas to fine-tune the development, right? So we use these posters as advocacy to get more ideas in small groups, and mainly you saw they were like walk-through discussions, and from all this, several interventions were identified for change. Maybe I won't read out all these interventions because you can see that the change was becoming a complex kind of an intervention. And by the end of 2010, we conducted a 2-day scientific and policy forum where the evidence from different studies, pilot projects that had been implemented in relation to primary care were presented for discussion. And the policy unit also presented the proposal highlighting the interventions that were required. And it was at that forum the Ministry of Health took a decision to pilot intervention with these pilots for primary healthcare strengthening in 3 locations in Sri Lanka. So this is really carried out as a development pilot. So some of these tools and guidelines that you see, which we are going to use later on, were the result of the development pilot. So there were new protocols, tools that were identified. Early developments to introduce simple health targets for lifestyle change were also identified, and this has been now launched by the College of Community Physicians as the Super 8. And now it is being adopted by the Ministry of Health for population-wide intervention through the Health Service Network. So what is then the proposed policy reform? The proposed policy reform comes, or we rather call it, shared care cluster system. A shared care cluster is considered as a unit where a specialist care institute functioning as the apex hospital providing general specialties of care will be considered as a cluster together with its surrounding primary care curative institutions. The objective of this reform is to provide universal access to continuing care, making the best use of the existing system with optimum use of resources. To bring about a system of accountability of care, as a shared care cluster will have its defined catchment area. So what was only defined for preventive and community health services, there will be defining of catchment areas for the curative services also. The concept of clustering of institutions for better resource sharing is also now endorsed by the Ministry of Health and declared by the Secretary of Health as an innovation to improve the health system. The Director General of Health Services has taken this forward, and the Organization Development Unit, together with Primary Healthcare Development Units, have identified 4 districts in Sri Lanka. That is one in the north, Vaunia district, a province called Sabaragamuwa, one district is Ratnapura, and Putla in the northwestern province, and Anuradhapura in the north central province are identified for full implementation. The WHO country office has assisted us with the GIS mapping to better understand how the clusters should work. At this point, the districts are now doing their institutional assessment and will be ready for planning meetings at local level. So that's the present status of what the shared care cluster system will be. Ministry of Health also conducted consultation with 9 medical colleges on how the medical education programs can be better geared for this change. Because what we felt was the undergraduates are more focused for specialized care management. They have worked more in specialized settings rather than primary care settings. So their program also needs to be uplifted for primary care. Then the recent batches of post-intern doctors who are assuming duties in primary level curative institutions, about 500 of them have been given an orientation organized by the primary healthcare unit in the Ministry of Health. So this is the ones who are going now into the primary level institutions, receive this orientation. on the new ideas regarding the guidelines and tools that I mentioned earlier. Now, while the shared care cluster system will rationalize and make government allocation more efficient and effective, there is still the unfinished agenda of examining the healthcare financing policy. While some initial studies have been done on the financing aspect, this is one area we need to work on more, on how the financing can be improved. Over time, the government has allocated more funds, but we see this is not enough. But what we get, we can certainly rationalize by improving this kind of the organization system. We can rationalize further. But there needs to be more funds coming in order to take this to a higher level. Thank you very much.
Okay, I'd like to thank Dr. Perera for that presentation. Before we go to the question time, I'd just like to remind people that we'll be continuing with the first session of the workshop at 2:30 this afternoon in the same room. And it'll be on the origin of the World Health Organization and evolution of international health. We have 3 speakers who will give very good presentations. And then at 4 o'clock, we've got Dr. Daniel O'Connor from the Wellcome Trust, who's the head of medical humanities at the Wellcome Trust, who will be speaking about humanities and the social sciences and about funding opportunities for research through the Wellcome Trust. So I'm now going to pass over to my collaborator, Dr. Sanjay Bhattacharya, who's head of our Collaborating Center on Global Health Issues at the University of York, to moderate the question. Thank you.
It's wonderful to see so many of you in the room. If I could remind you, we have colleagues listening to us over the internet. So when you make a comment or ask a question, please identify yourself in the hope that, someone who's listening in might actually want to correspond with you, communicate with you. We're going to discuss the issue of communication in global health at greater length in the workshop. So, it's just a further plug for the workshop that's coming up. Does anyone want to ask some questions? Or, Madam? Can you use one of your...
And it was a difficult time for the country, difficult time for the people.
Madam, can you identify yourself?
Yes, my name is Dr. Jordan, and I'm a speaker at the UN for People Health Movement. I wanted to know various things. First, by that time you had some hospital, one specialized hospital for sight, that was stopped. The buildings were there, but for the question of money, nothing was moving. And I would like to know if that has been achieved, because you had a lot of problems at that time on site. And speaking about that, I would like to know if you are continuing to see the children at school. There was once a year a visit by some specialized persons from the capital. Sorry for my English. I try to be nice. We were helping the children to be extremely careful on that question of visual problems. And I would like to know if it does continue, if the children are still doing that themselves at school, because it was extremely interesting seeing all those youth taking care of each other. I would like to know if that hospital that was near the airport has been finished, has been finalized. It did exist, people were there, but no surgery more than, let's say, 3 hours was possible because there was no enough electric power over there. And it was possible by that time to have money from the European countries, but it was impossible for a year to obtain any of administrative paper we asked to the government, which was a pity, but it was like this. I would like to know how long is the line for going to the main hospital in the capital, because sometimes people were waiting more than 1 day. And they were asking, giving money for some people in front of them in order to gain some numbers, if you want, some lines. And some people were living on that. They were coming very early the morning, giving their space in order to have a bit of money. I'm sorry, but it's because I love that country. And the people, the doctors were absolutely marvelous. And I would like to know why you had the government gave more money in private medicine for a few years than in public medicine. Because I could see also the handicapped children, especially on bones problems, were not taken in charge. And it was absolutely terrible to see how they were. Another thing is the mother, the health of the mother, primary health care, let's say, were not taken really in charge, but maybe it was because it was a war. So I would like to know what happens since. That would be extremely important, because I have been knowing some women, some young women, dying of epuisement, I don't know how to say, of fatigue, and that shouldn't have been. And the last thing I would like to ask, because it will be too long for everyone, it's the medicine for young women working in the field, working in, how do you say that, factories. That was absolutely terrible. The pregnant women didn't have the time to go to the toilet. All the women were abused automatically when they wanted to keep their job inside the factory. And I suppose you have been knowing, if it's somebody of Vivienne, that marvelous woman who had been, whose husband has been a minister, and she was a very active union member. And we have been doing together some days with the workers of standing up into the heat for the possibility of those women to have more health, more possibility to be living as a human being should be living, and as a worker should be living. Now, I'm saying I love that country, and the doctors, the way they were working, I admire them.
Madam, I think we should.
Thank you very much now.
Yeah. Let our speakers respond. Yes, please.
Thank you, Madam, for your concern. There were several areas that I just jotted down. Yes, the school health program is doing very well. We are continuing with the school health program. Year 147 all examined every year in all schools. Coverage is very good. And you mentioned few areas. One was on handicapped children, occupational health, about those. Now, yes, there are. We do have issues on children with special needs, and that is an area that the Ministry of Health is trying to reorganize to have a better program. That is an area that we need to emphasize. Similarly, occupational health, largely it has been taken care of by the Labour Ministry, which has its own occupational health division. But I'm not trying to, as a government person, I'm not trying to pass the buck on to the Labour Ministry, which is certainly not the case. We are expanding our occupational and environmental health services in the Ministry of Health. And very soon there will be an occupational health and safety policy which is being discussed between the two ministries, Labour and Health, which will focus on this. And certainly when you spoke of the maternal outcomes, I mean, it's reflected in the overall trend that I showed you, because the maternal deaths are very few now. And most of these deaths, the causes when you analyze are also due to non-communicable diseases, mainly on heart diseases and so forth. Right? But certainly the situations are different now. I don't know exactly which period you're referring to when you visited Sri Lanka. Regarding infrastructure development, I mentioned about the development. See, we can't always, we can't really fit well the development as well as the human resource deployment. So sometimes in some instances, the hospitals have grown and maybe we did not have enough health personnel. But see, and electricity, I'm not sure whether, because now the country has, electricity is everywhere, even safe water. I mean, I didn't even speak of those because the coverages are very good now. Sanitation and water, I didn't even speak because it has, the picture is completely different, right? And regarding the money that some people extort from people who access outpatient care in bigger hospitals, this is the very reason why we want to reform, to have a better system of access so that people don't have to wait for long times. In fact, we are discouraging people coming very early. Now they are given appointments now. Even in the smallest hospitals, we are trying to, because it's a culture change of giving appointments. Because most of our countries, we have a situation where they will queue up from 5 o'clock in the morning, thinking that they can get a first come, first served basis. But what we are trying to do is, by improving access to the closest hospital, they don't really need to queue up from 5 o'clock in the morning, right? So already some institutions have already done this. Right? Yeah, but I'm very happy about your raising that you raised, the concerns that you raised.
Woman and then sir.
Well, my question is named structure. You mentioned at the beginning that Sri Lanka was treated sort of differently to other British colonies in terms of, I'm not sure whether it was favoured or not. But I wasn't quite sure why did that happen? I mean, why was the British colonial administration treating Sri Lanka differently to the other colonies in terms of health services and access to health?
Okay, well, that's an interesting that's an interesting question. I wouldn't say that it was treated differently because the imperial government did not influence over much what went on in particular colonies. I mean, they oversaw what went on, but it was very much left to the colonial government within a particular colony. And I think this is just the way that it evolved in Sri Lanka. And I think partly because, as I said, that the role of the medical profession, I think, was very important in Sri Lanka. The reason that you had a medical college in 1870 in Colombo stemmed from a report by a Sri Lankan doctor on the babunya, which was a very poor. Can you hear me? No. Oh. Okay. The region of the medical college, not all British colonies had medical colleges themselves, was because a Sri Lankan doctor made a report on the babunya, which is a very poor rural area in Sri Lanka, and put in a plea for what he termed, native doctors to minister to the natives. And this had a great influence on the head of the civil medical department. So I think I was trying to kind of argue that one reason was that you had a medical college in Colombo, and if you look, as I have done, and you trace the expansion of hospital services, curative services, you can see that their pressure on the government was quite instrumental in expanding those hospital services to other areas. So they put forward crucial arguments why this should be done, because obviously it was in their professional interest and not just humanitarian. Secondly, Sri Lanka was a wealthy colony. So, I mean, obviously the wealth was preserved to the elite few, but it was a wealthy colony in terms of colonial terms. So I think the money was there to put in place. So it was very much what was going on in Sri Lanka rather than the imperial government choosing to do this.
So, thank you very much indeed, and I apologize if I missed the last maybe half an hour of the second speaker, to Perera. I'm sorry about that. I think the quality of sound was terrible, and still is. I think one of the problems that we often miss as healthcare providers is the mechanism of funding as a tool to improve healthcare. And that's probably explain the reason why we have noted a huge conflict between primary healthcare and therapeutic healthcare in Sri Lanka, as pointed by the first speaker, because they're both competing for the same source of funding, which is that 3% of GDP from Sri Lanka. So the question I'd like to ask Dr. Perera as an analyst and development for plan for the Ministry of Health, have you considered health saving accounts as a potential way to solve the conflict of healthcare provision, at least for the therapeutic healthcare or the secondary and tertiary healthcare part, and within the Ministry of Health in Sri Lanka? Because if I'm allowed, give me 2 minutes, I'll just explain a common example I often quote. If you look at in America spends $7,000 per head per year on healthcare provision, yet the health system in America counts at number 36 according to WHO ranking, whereas Singapore spends about $800 per head per year, yet the health system in Singapore ranks number 6 in the world. And the secret is the health saving accounts, which you're actually keeping the patient or the individual as the primary responsible on decision making on how much and when to spend on healthcare. Thank you. I'm sorry, can you identify yourself?
I'm very sorry. I'm Dr. Al-Aufli. I represent Libya within the WHO. Thank you.
Yeah, I agree. The financing aspect was not really touched because we are actually examining that as what should be the financing policy. The general tax-based financing itself contributes to the pool, and the private spending is very, very small. Out of pocket is very high. Insurance by far and large is a very small component, but we are toying with the idea of how we can have a national insurance system, but certainly we have a long way to go in putting, doing the analysis for that. It's politically very, very tricky, and having this free health system for a very long time, but we are drained with how we can continue to do this. Pooling funds of people who can actually save and we can distribute it equally in a different way is something that we need to discuss. Recently, we started off by doing cost accounting, introducing giving a kind of a dummy receipt or with a bill, I would say, just to say that this is how much we spend for you, for your hospital stay in government hospital, just to sensitize people how much the government pays. This is not just to say that we are going to abolish the free health system, no. It is certainly the government identifies, even in the recent policy document, the government explicitly states that the system is for people who less afford. That is why the government is encouraging private sector growth. But the insurance can certainly be pooled. Right now what is happening is there is fragmented insurance systems developing, even for the people who can afford. So we haven't really done that analysis, whether there can be savings funds. It was introduced saying that from the pensions that something can be put in, from the employment savings that something can be put in, but that was, not very politically savvy.
Yes,
if I'm allowed to explain to you how the health saving account in Singapore works, where from the day you start working, they take 7% from your salary and deposit into an account only to be used for healthcare provision. At the same time, the government put about 7 or 10% of your income into that account. So the 3% which is being spent from GDP from the government, if you take two of these 3% and distribute it to individual only in a health saving account to be used only for healthcare service, whether private or government, I'm sure you will notice a huge difference within a few years in terms of provision of better quality healthcare and also control of the amount of money you'll be spending on health. It's not a pool system. I think that the usual mistake is that people pool that amount of money and distribute it between all individuals. There's not an incentive for individuals to save. But if you make it this, whatever you save, whatever the government put in your account, it will remain for you and for your children after you, and can be used by your immediate family or yourself. It's a positive incentive for these individuals to save that amount of money and not overspend it, for example. So he always think twice before he goes, for example, to see the most expensive cardiologist, for example, in town. He may see a relatively cheaper one for the same quality of care, we hope, because the government will supervise the quality of healthcare being provided by these both types of cardiologists. I think the idea is pooling is bad. For the government to provide a national health insurance also is not useful, because you end up using private healthcare insurance, which is very expensive in the long term. We've seen in the last 10 years or 12 years in America, the cost of healthcare has doubled for family. Instead of $6,000 per year for a family, is now more than $12,000 or $13,000 per year to have health insurance, because it is a private healthcare insurance. But if that amount of money, which we say health saving account, was utilized and invested by a national, not-for-profit making organization, you'll find that whatever money you put aside for health will grow. It's important to realize Singapore is the only country probably in the world that they have about 12 billion Sing dollars in surplus for healthcare expenditure.
We're going to take one question through the internet and then the lady there. Basically, Professor Anne Emanuel Byrne from the University of Toronto wanted to know from Dr. Margaret Jones more about the political context of various periods. She also is a bit baffled by the argument that it was a positive colonial legacy that set the course of primary healthcare in Ceylon and then Sri Lanka, and wonders why Dr. Jones did not refer to resistance movements and the role of the Communist Party. Would you like to respond or engage?
Rather a large question list. To start off with the colonial period, as I said at the beginning, you had a highly westernized elite in in Sri Lanka, in Ceylon. And it was a very civilized, if you like, decolonization process on the whole. I mean, it's not India. And what happened in 1931 was that you had universal suffrage, so that you had almost 20 years when Sri Lankans were ruling themselves. You had a minister of health who was a Sri Lankan who was in charge of health at the time. And the transfer to power was fairly conflict-free. Obviously, Sri Lanka has had enormous conflict since then, but the transfer of power was also fairly conflict-free, and all governments from the 1940s onwards have committed themselves to providing free healthcare. It's been one of the kind of basic, it doesn't matter what flavour the government was, they were always providing free healthcare. The left-wing movements, the Marxists became prominent in the 1934-35 malaria epidemic because they made a great thing of going out into the villages and helping people, and they got support there. As I say, I can't really answer some of this without going into the whole history of Sri Lanka, but maybe Julie can help. But I think the important thing for the context, for the decolonization context, was that Sri Lankans were in charge. They were in charge of their medical department and they were in charge of their government from 1931 onwards. And although as I've argued, there were deep roots to primary healthcare in Sri Lanka, it was cemented in that period up to from 1931 to 1948.
Thank you. Well, colonialism wasn't the same everywhere, so yeah. Anyway, Margaret.
Dr. Jones and Dr. Perera, thank you so much for the presentations, and it was great going from the history to the present, and I'm sure some of the things that you raised basically for the history still hold true today in many countries. My question would be with the present.
Could you identify yourself?
Oh, yes. My name is Vibhu, and I am working with the Office of the Assistant Director General for NCDs, NMH, Non-Communicable Diseases and Mental Health Cluster at WHO. And I know that Sri Lanka is doing very well in terms of the National Action Plan for the NCDs, and there are constant regional meetings happening also. I'm just quite interested in understanding a bit more, and I know you said, Dr. Perera, about the availability of essential drugs for NCDs, and also there are facilities for screening and management for NCDs, particularly the CVD, the cardiovascular risk factors. So I'm just wondering, it must be very challenging first, and the cost to the government, or is it very well laid out, and the cost may be out-of-pocket expenditure for the people? And just last one thing about when you showed the map initially, and that's just literally on a personal level, I see a lot of concentration on the western side when we're talking about the health facilities. Is that true, or I probably saw it differently? And then eastern side looks a bit sparse, but thank you.
I'll respond to the last one about the map. There are a lot of dots actually on the coastline, right, from the eastern part. Where you don't see dots are because there are forest areas and population is less sparse, so you actually don't need many health facilities, and the road network is good, so people do access. The other one, yeah, I mean, see, over the last 3-4 years, especially, we had a huge emphasis on screening. It was almost as if NCDs, the marvel, thing is to screen, and quite forgetting about all the other elements that need to be there for managing non-communicable diseases. And if you screen, what do you offer them next? So those are some of the things that we in fact, when we looked at the model and how it was appearing, because largely it's very very attractive screening. Even I mean, anyone, any local politician would like to organize, not saying politicians, that's what they understand, and maybe it's good to encourage that. But we needed to have a system where even those who identify as risk, people with risk, even if they don't have a disease, right, they need to be guided if they have risk and guidance. So that is why we brought in the system of healthy lifestyle centers and about specific guidance. And even, I mean, I didn't have time to elaborate a lot, but even the Super 8 that we mentioned of is also for that. Because we needed some kind of a social marketing approach just to uplift general understanding, because it needs to be a population-wide intervention to increase the level of understanding, rather than just to haphazard screening. Right? So, unfortunately, the screening part is what people identify as the NCD program. Right? But it is not really that, because the NCD policy speaks a lot about reorganizing, and I think the investigation that we did and what we are putting it really puts care for non-communicable diseases in the right perspective, because they are looking at chronicity. Regarding the essential drugs, yes, essential drugs are made essential for primary care, but what we found was still the mentality of the whole system for distributing the drugs between the secondary, tertiary level and the primary level. Still, the local administration, the provincial directors, the way they estimate drugs, we have a full system of estimation of drugs, and then procuring everything depends on the estimates that are sent from by each and every hospital. So they, in fact, some of the very recent investigations are showing that we are not estimating enough. Right? So maybe there will be redistribution once we start monitoring. The very preliminary work that we did on the pilot shows that that monitoring system is not enough at the local level to understand that the drugs need to be put there. So we have to measure stock-out positions for these drugs.
We have a connected question, Dr. Perera, from Professor Jeremy Green at Johns Hopkins University, who asked if you could comment on the changing role of pharmaceuticals in primary health care since 1948, I suppose.
At the time, during that time, it was really to manage hookworm infestation and iron supplements. Those were the main drugs that were put in, and thereafter the drugs and devices for family planning, the reproductive health program. Still, vitamin supplementations are widely given for the maternal and child health program. But here now we are talking of primary health care as curative and the preventive program. So now we are sort of not saying that these essential drugs are what we have identified for managing the most prevalent non-communicable diseases in the primary level network of curative hospitals.
Okay.
So it's kind of changing. When we say PHC, it's really that whole primary level that we are considering curative and the preventive part. But the health units really take care of the preventive promotive health.
There's a secondary conceptual question as well. I mean, he would be interested in your thoughts about how the role of pharmaceuticals in primary health care, for example, in the treatment of HDN or diabetes, complicates the distinction between curative and primary care. As an health administrator, do you see that as a problem? Is there now a less sharpened division?
Yeah, I know. It's like you're waiting till people get sick to manage, rather than are you adopting prevention and promotion. Well, I think Sri Lanka is still very strong on prevention and promotion. That's why, I mean, screening was like a kind of a thing that quickly rushed into the picture. But that's why all the guidelines for understanding the knowledge gaps in primary care level workers and how they need to be strengthened and supported on the Super 8, actually, the 8 elements, those were all very carefully structured to give specific knowledge to the healthcare staff so that they knew what to say. Because we felt that when we did certain examinations on their knowledge levels, we found that whatever you have educated them, they needed some very clear messages to go. So that's why I think, yes, we are putting a lot on prevention and promotion. It's a difficult path, but it will pay dividends in the long run. But you have to get medication because a large population are already affected, right? So it's very high, like diabetes and hypertension are very high. So you have to treat people, but we also want to prevent people from getting, or at least delay the onset.
You have a question from Colombo, from Dr. Ranjan,
Yeah.
for Dr. Perera.
Okay.
Can you please explain how the government maintained a reasonably efficient health system in the north and the east of Sri Lanka during 30 years of conflict?
I think we did well, because I mean, if you look at the health indices itself, and also I mean overall maternal mortality and immunization, especially, those are the main things. We really did well, and I mean we had special policies to retain staff. It was difficult. I'm not saying that. I mean we had 100%. I mean equity in all sense, but we did well. And I mean maybe I need to elaborate a little bit more, but I mean I myself have been to most of these areas during the time of the conflict, and in fact we even changed how let's say the teaching hospital just now, we knew that it had to be supported tremendously if we are to retain good health professionals in that area, because health professionals want to be identified with specialty care. So if you improve the level of specialty care, you can retain people, and then they would be training the others. So like that, there were a lot of things that the government did, and got the assistance of JICA to help develop the teaching hospital Jaffna. I mean, I think it's very important that even the analysis on primary healthcare development was done to really give a good model in the restoration phase for the north. So I think that's why even the implementation, we are looking at Vaunia as one. I think the whole of the north will take up this model because it's very relevant, and it fits in with the populations, and primary care development is possible because there are small populations and they can access well, and now the doctors have gone there. Not saying 100%, but I think the model will do well with the north.
We're running short of time. What I would suggest is there are some sandwiches outside. We continue talking there. We then bring the sandwiches back so that we can continue with the workshop on time at 2:30, if that's all right. I think Madam there would like to, but why don't you ask the question and then we can come back to it when we have the workshop. Ask your question. Come and identify yourself and ask your question. Please, use the...
I'm Helen Wolf. I'm a volunteer here with the WHO and a research fellow based at universities in London and Australia. I'm interested in how the healthcare system, or the health system more generally, is responding to the epidemic of kidney disease in central and northern Sri Lanka, where I've heard that up to about 80% of hospitalisations are due to kidney disease. Thanks.
I think I listed this out as a major concern that we are having. Well, here again, the government wants to screen. So the policy is that everyone above 10 years will be screened. The issue is what we are going to offer them after screening. So it's really the clinicians have got together in that area, and they will have a program where it will be follow-up, because you can't actually, I mean, once somebody is identified, it is changing the progression of the disease. So managing hypertension, managing lipid control, changing habits like tobacco, alcohol use and all that. So that's the path that is being taken, because several may be affected. But in the longer run, it needs a multi-sectoral effort on water, farming, pesticides, all that. So discussions are going on for that kind of intervention. But the immediate response, and I think the government has put in a lot of funds for chronic kidney disease, and certainly, I mean, at the moment what you're doing is that, and improving dialysis facilities and all that, but I feel that the multisectoral effort is going to be the one that you have to really look at to see the intermediate, in the intermediate phase.
I think speakers deserve some healthy sustenance in the form of sandwiches. So I'd like to thank them for two